Yeah. Yeah, Paramount people. I feel like some people lectures are pretty good person. I don't know, it's just because it's for the small space. Everything's right. It's all optics. So you think you a lot about it. Yeah, and that's share. I would have. You don't have to. Yeah. She's talking you want. Okay, it's easier to say.
Good afternoon. It's my pleasure to introduce Dr. Nirali Shah, who is Associate Professor of Medicine and Director of Ambulatory Services for our division here at Mount Sinai Hospital. And she is the inaugural recipient of the Teacher of the Year Award, which was started to give the fellows an opportunity to select the person that they thought was most deserving of really a very, very high honor of being a distinguished teacher. And then Alice Levine had the really inspired idea that particularly during fellowship recruitment season, we should have our Teacher of the Year recipients give presentations so people who are interviewing for fellowships here can see how outstanding our faculty are. Nirali graduated from a medical school in India, the NHL, National Hockey League Municipal Medical College, and then came to the United States where she did her residency and was a chief resident in internal medicine at Stony Brook, and then came to Mount Sinai for endocrine fellowship. And one thing we're very proud of here is how many former fellows we retain as faculty members. And it's really a great pleasure to see them grow and develop into their own successful independent academic careers. And in fact, Nirali received support from the institution to do training and a master's of health administration. And so really to branch out into a specialized area. She's also participated in clinical trials here and on a national level is involved with the American Association of Clinical Endocrinologists. And today she's going to talk to us about GLP agonists, the good, the bad, and the ugly. Nirali.
Thank you. I'm hoping this talk today is relevant to everyone watching because I personally feel like GLP-1 agonists have become the most clinically relevant drug category, and not just that, but also one of the most rapidly developing. These are my disclosures, none of which are relevant to this talk. So our learning objectives today, we're going to summarize the efficacy of GLP-1 receptor agonists and dual GIP-GLP-1 agents in T2D and obesity. We're going to interpret the major outcome trials and their application to care, identify medications that are currently in the pipeline, and recognize common and serious adverse effects. So a little bit about the history. So initially, incretins were recognized back in the 1980s. It was coined the term glucagon-like peptide because that was the initial structure, was very similar to glucagon. And it was only later on that it was found out that this particular molecule had different effects on GLP-1 and GLP-2 receptors compared to that of glucagon. And this little guy here, the Gila monster, he is our source of au naturel GLP. So back in 1990, Dr. Eng identified exendin-4 in the saliva of the Gila monster. Until then, we were aware of human GLP, but it was rapidly degraded in the body by DPP-4 inhibitors and would only last 1 to 2 minutes. So it was not at the time clinically relevant. After the identification of exendin-4 from this guy, we were able to find that it was resistant to DPP-4 degradation and had a much longer half-life. And it could activate the GLP-1 receptor in humans almost identically to GLP-1, but with a sustained action.
And you know who Dr. Eng was?
No, I do not.
Oh my God, he was at the Bronx VA.
Oh, Dr. Eng was at the Bronx VA. There we go. So a little plug-in for the Bronx VA. So this is the history of GLP-1 receptors. So back in 2005, we had the first Byetta, which is exenatide, which was dosed twice a day. Then in 2009, we had liraglutide Victoza, which was a once-a-day injection. 2014 came the time of once-a-week GLP agonists, Trulicity, Tanzium, which is no longer available. And then liraglutide was FDA approved as Saxenda for weight loss. And then in 2017, we had semaglutide injectable approved, followed by oral semaglutide and injectable semaglutide for weight loss. And finally, we had tirzepatide come into the field in 2022 as for diabetes, brand name is Mounjaro, and then in 2023 as Zepbound. So a little bit about the mechanism of action of GLP-1 receptors. So GLP-1 is secreted by the L cells in the small intestine in response to a glucose or fatty load in the stomach. The GLP-1 receptors then work through G receptors and a multitude of different organs. Predominantly in the pancreas is known to help increase insulin synthesis only in response to glucose. This makes it very different than other diabetes medications on the market, such as SUs, which persistently increase insulin secretion regardless of whether there's exposure to glucose or not. It helps regulate blood glucose levels. And then there's also data suggesting that it has islet beta cell protection and proliferation, some of the data which I believe Dr. Stewart's lab has shown. In terms of the liver, there is decreased gluconeogenesis, decreased liver fat content with reduction in hepatic steatosis. In the GI tract, it is known to cause slowing of gastric emptying and reduction in peristalsis. In the brain, it actually increases the signal level of satiety. And then there is a lot of data going into its synaptic transmission and effects on memory. But there are no large outcome data yet. And so we're not really going to focus on this part here. In terms of the heart, there is data to show it has cardiovascular protection by working through anti-inflammatory actions on the endothelium, reducing blood lipids, as well as increasing atrial natriuretic peptide. So what about addition of glucose-dependent insulinotropic polypeptide, GIP, agonism in addition to GLP-1 receptors? So what's very interesting is that GIP agonism on its own, it's secreted, again, in response to a food load in the stomach by the K cells of the small intestine, secreted a few seconds to minutes prior to GLP being secreted. And what it actually does when it is stimulated in an acute situation is it has receptors in the subcutaneous white adipose tissue and actually can cause fat accumulation and increase lipid buffering capacity. But when used in a chronic stimulus at the GIP receptor, it is actually known to mobilize subcutaneous white adipose tissue, increasing basal thermogenesis by a mechanism that's recently come to light of calcium buffering in the cell, which increases ATP utilizations in the cell. And then in the central nervous system, it has a particular effect of reducing food intake, as well as reducing nausea. One of the reasons why it has allowed us to be able to increase the doses of GLP-1 receptor agonism, which we know increases nausea, and thereby helping with reduction in both glycemic control as well as weight loss. So what about the good? So we'll start off with the glycemic changes because that's where initially these drugs were studied. So we're all familiar with the SUSTAIN-1 trial. This is the efficacy and safety of once weekly semaglutide monotherapy versus placebo in treatment-naive patients with type 2 diabetes. And the doses studied in that trial were semaglutide 0.5 milligrams once a week and semaglutide 1 milligram once a week in comparison to placebo. And what we can see here is the reduction in A1C of approximately 1.5% with the higher dosage. And in terms of weight reduction in these patients, we saw a total of between an average of 4 to 7 kilos of weight loss at the higher dosages. And this really where we saw the high amounts of weight loss became the basis of the further clinical trials, which looked into it for weight loss management. So what about the rest of the SUSTAIN-2 and 5, as well as 7 trials? They compared semaglutide to its predecessors, sitagliptin, exenatide ER, which we know as Bydureon, insulin glargine, and dulaglutide. It consistently showed greater HbA1c reduction and weight loss versus its comparators. The Pioneer-1 trial was oral semaglutide, also effective in lowering HbA1c of an average of 1 to 1.5%, and in reduction of weight by 2.3 to 4.4 kilos in patients with diabetes. And this confirms semaglutide's role both as an injectable and an oral therapy for type 2 diabetes. So now came in the next player in this group of medications, tirzepatide. So this is the SURPASS-1 trial, which showed the efficacy and safety of a novel dual GIP and GLP-1 receptor agonist, tirzepatide, in patients with type 2 diabetes. The doses studied in this trial were 5, 10, and 15 milligrams. The intermediate dosages were meant just as a step-up medication dose. And as you can see here, the average A1C of the group was around 8%, and there was a drop in almost 2% of A1C, which was previously kind of unheard of other than insulin. And in terms of weight changes from baseline, we can see here that at the highest dosage, we had 11%, at the lowest dosage had almost 8% weight loss. And the remainder of the SURPASS-3 to 5 trials, again, compared tirzepatide to its predecessors, such as insulin degludec as add-on therapy to metformin plus or minus an SGLT2 inhibitor, tirzepatide versus basal insulin in high cardiovascular risk patients with type 2 diabetes, and tirzepatide as an add-on to insulin glargine and metformin. And in each and every one of the scenarios, we were able to see that despite being on basal insulin, this medication was still capable of causing weight loss in patients with diabetes, which was very important because all of the prior medications, including SGLT2s, when added on as a second or third medication for diabetes, were weight neutral at best. And so this is the SURPASS-2 trial. So this is really where King Kong kind of took on Godzilla, where we had semaglutide and tirzepatide go head to head. And so this was a study of tirzepatide versus semaglutide once weekly as an add-on therapy to metformin in participants with type 2 diabetes. And as you can see here, there was a 2.3 average reduction with tirzepatide at its highest dosage of 15 milligrams. And it was compared to semaglutide 1 milligram because that was the only dose currently FDA approved, which was 1.86%. And for the individual dosages for tirzepatide, you can see here that these were the average A1C reductions. This was tirzepatide 5 milligrams, tirzepatide 10, tirzepatide 15, and this was semaglutide at 1 milligram. And tirzepatide was shown to be superior to semaglutide 1 milligram for A1C lowering. And then this was the weight reduction, which we saw in kilos. Again, tirzepatide 5 being a little bit more comparable to semaglutide 1. But tirzepatide 10 and 15 definitely shining over semaglutide 1 milligram. And so since these trials showed a lot of weight loss, the next step was moving on to what about weight changes? And the reason for doing specific trials on patients who did not have diabetes, but purely had obesity was because the mechanism of weight loss in diabetes and in obesity with no diabetes is very different. In patients with type 2 diabetes, we have insulin resistance contributing to the weight gain. And when we're seeing weight changes happen in those patients, it's really, some of it is coming because of the fluctuations in the insulin resistance. Also, the patients with diabetes tend to be on medications that tend to be lipogenic, whether it's insulin, SUs, And so the amount of weight loss is usually generally lower in patients with type 2 diabetes than those with just obesity. So the step 1 trial looked at once weekly semaglutide in adults with overweight or obesity. And again, the percent change of body weight, which was its primary outcome that you can see here. This is placebo, this is semaglutide, averaged around 14.9% compared to the 2.4% with placebo. And these are the remaining step clinical trials that looked at semaglutide. It's a very busy slide, but most of it was just comparing semaglutide to lifestyle interventions, intense behavioral therapy. Some of the step 6 and 7 trials were focused on the Asian subpopulation, but I want to draw your attention specifically to step 8 and step 4. The step 8 trial was in adults with obesity, no diabetes, and it compared semaglutide to liraglutide 3.0 milligrams, which we know is Saxenda versus placebo. And at that time, semaglutide was found to have more weight loss of an average of 15.8% versus the 6.4% of liraglutide 3.0. And at the step 4 trial, which we'll talk about a little bit more later, this was a trial where there was a 20-week run-in with semaglutide. Then patients were either randomized to continue or move to placebo, meaning no further therapy. The patients who continued had continued to have a 7.9% weight loss versus those who stopped the medication had a 6.9% regain. So overall, the step trials, the strengths versus limitations, they were large multi-center international randomized control trials, strong efficacy with a 15% average mean weight loss. There's consistency of weight loss across both obesity, whether or not there was type 2 diabetes or not. It showed robust cardiometabolic improvements, and they were carefully monitored safety and tolerability. It included lifestyle counseling as a background. Its limitations, a majority of the trials other than step 6 and 7 were focused on a predominant Caucasian population, predominantly white middle-aged women. So it had a little bit of limited generalizability. The duration was 68 weeks, which seems to be a long period of time, but when you're talking about patients taking these meds chronically, it's not as long as we would want. Weight regain after withdrawal was was something that we're going to talk about a little bit further, and excluded many patients with comorbid conditions such as psychiatric issues. It had a limited focus on lean mass. So where's the weight loss coming from? And again, we'll talk about this point a little bit further down the road. And in terms of safety, the rare events like pancreatitis, gallbladder, retinopathy, optic neuritis, they require longer term follow-up. So SURMOUNT-1 was tirzepatide once weekly for the treatment of obesity, looking at 5, 10, and 15 milligrams. And as you can see here, the average weight loss was rounding between 15 to 20%, which was unheard of up until now. SURMOUNT-5, again, we have tirzepatide comparing itself to semaglutide 2.4 for the treatment of obesity. The comparison was that tirzepatide had an average weight loss of 20.2% in patients with no diabetes but obese, and semaglutide was 13.7%. There were also preferable changes in waist circumference seen in tirzepatide over semaglutide. So the summary of the SURMOUNT trials, the 2, 3, and 4, was really, again, looking at weight loss, tirzepatide in patients with obesity and type 2 diabetes, where we can see here the weight loss was 12.8 to 14.7, a little bit less than what we would see in patients who do not have diabetes. In terms of SURMOUNT-3, it was an add-on therapy to patients who had already tried lifestyle modifications in the past and was still able to show that there was an additional amount of weight loss. And then finally, SURMOUNT-4, very similar to step 4 trial, looking at semaglutide and stoppage. This looked at stopping tirzepatide and then randomizing to placebo. And it again showed that the patients regained 14% of the weight. So what's in the pipeline? So we've been using these medications for quite some time now. So obviously there's probably more in the works. So these are a bunch of phase 3 trials, again, medications that are not FDA approved, but are still under investigation. So OASIS-1 is the trials looking at oral semaglutide, 50 milligrams, taken once per day with adults with overweight or obesity. And so obviously we have a bunch of patients who potentially have injection fear, may not want to take injectables, may not know how to or have the dexterity to. And so this oral category kind of gives those patients an option for treatment. And so in this randomized double-blinded placebo-controlled trial done over 68 weeks, it showed a mean body weight reduction of 15% with semaglutide oral versus 2.4% with placebo. The key thing, though, was that there were significant increase in GI adverse events, 40% in semaglutide versus placebo, 27%. One might ask, why did the placebo have such a high rate of GI side effects? So it was prompted questionnaires, and so there's a bias that patients may be more likely to report things. But two, we know that there is some gastrointestinal dysfunctions that exist in patients with obesity. They tend to have more heartburn, and so they're more likely to be reporting out these symptoms even at baseline. What was surprising was the discontinuation rate. It was 12 to 13%. In the prior injectable medications, the discontinuation rates were around 5 to 8%. So definitely we're seeing an increased amount of discontinuation. So currently we have a trial, there's a trial ongoing, data which has not been reported yet for OASIS 4, which is looking at 25 milligrams of oral semaglutide and is under FDA review at that dosage. So now that we've talked about that oral GLP agents can potentially cause a lot of GI adverse effects, what about how do we kind of bypass that particular mechanism? So one of the medications that's under investigation are non-peptide-based oral GLP-1 agonists. So the difference between a peptide-based oral GLP-1, which would be semaglutide, is that they have different receptor binding kinetics. So they bind allosterically, and therefore may partially activate GLP-1 receptors differently in the gut and CNS than what we see with semaglutide. So this is a picture of a G receptor. The semaglutide and the peptide-based oral GLP agents are all binding to the extracellular component of the G protein, whereas these non-peptide-based oral GLPs are actually binding to the transmembrane portion of the G receptor. And so what we believe is happening is that they may not activate a route called beta-arrestin, which is part of the pathway of activation of the G receptor. And that could then lead to less stimulation of nausea-triggering pathways, even if the metabolic activity is maintained. In addition, semaglutide needs gastric secretion. So semaglutide actually has an additive called SNAC, and that is a chemical which essentially increases gastric acidity at baseline. So some of the side effects that you may be seeing with oral semaglutide are actually because of that additive to increase gastric absorption. These non-peptide-based oral GLP agonists are actually different, that they don't need to be taken on an empty stomach and do not need those gastric absorption enhancers. And therefore, they also have supposedly have a more stable or predictable absorption. So the ACHIEVE-1 trial looked at a non-peptide-based molecule, which was oral orforglipron in people with obesity and overweight. And this was a phase 3 trial, randomized, double-blinded, placebo-controlled, all over a period of 72 weeks, and tested 6, 12, and 36 milligrams once a day compared to placebo and as an add-on to lifestyle. And the primary endpoint was mean % body weight change from baseline at 72 weeks. And the secondary endpoints were the proportion of participants reaching those thresholds. It is slotted for FDA submission in 2025 to 26, and the average discontinuation rate was 6 to 8%. So significantly less than the oral semaglutide, though we do not have the results of semaglutide 25 yet. And so what was the data showing? For the primary endpoint of % of weight lost, for the lowest dosage was 7.8% and extending up to 12.4% compared to 0.9% of placebo. And then the percentage of participants achieving 10% weight loss at the highest dosage was 59.6%, similar to some of our injectables. And the participants achieving more than 15% was around 39.6%. And so ATTAIN-1 was looking at the same molecule in the treatment of patients with early type 2 diabetes. And in this phase 3 trial, with patients had a baseline A1C of 7 to 9.5% with a BMI of greater or equal to 23, and they were given the medication for approximately 40 weeks. The mean change in glycated hemoglobin level was around 1.5% at the highest dosage and 1.2 at the lowest dosage of 3 milligrams. And then adverse events leading to discontinuation, again, we're seeing a dose-dependent increase in adverse events, with the highest amount being at the 36 milligrams and the lower dosage of 3 and 12 having a 4 to 5% discontinuation rate. Okay, so moving on, we had initially showed the data that tirzepatide was doing better than semaglutide. And so semaglutide needed to get back in the game. And so how did they do that? So that's where the REDEFINE 5 trial comes into play. So the co-administration of cagrilintide and semaglutide in adults with overweight or obesity. So cagrilintide, for those of us who do type 1 diabetes, know that it is a amylin, and it is very similar to Simlin that is on the market. Their amylin helps with slowing gastric emptying, reducing glucagon secretion, and promoting satiety. The difference between Simlin and cagrilintide is that cagrilintide is a long-acting, something that we always like. Simlin has to be dosed multiple times a day. And so cagrilintide is a once-a-week injection that was combined with semaglutide. And so you could see here the data, and the percent change in weight with a combination therapy was around 20.4. So trying to catch up to tirzepatide here. And semaglutide alone, as we know, stayed at 14.9%, and cagrilintide alone was actually 11.5%. And the gastrointestinal adverse effects were around 80% with the combination therapy, and placebo had an adverse event of 40%. Some of the limitations that, again, done mostly Caucasian white females, but this is FDA review is slated for 2026. Okay, so we had talked a little bit about recruiting a particular path of the G receptor to avoid gastrointestinal effects. So this is another new category coming out called biased GLP-1 receptor agonists. So what are unbiased agonists? Those are tirzepatide, semaglutide. Whenever they bind to the G receptor, they are actually activating the G protein, which increases cyclic AMP, and then continues on down the pathway to do all the effects that we see with weight loss. And then the beta-arrestin is also recruited, and that actually leads to receptor desensitization and internalization, but is also the part that is responsible for the gastrointestinal side effects. A biased agonist is preferentially activating only the G protein and not the beta-arrestin, therefore prolonging receptor activity and potentially causing lesser side effects. So the SLIMMER-3 trial looked at one of those molecules that are biased called the ecnoglutide in adults with overweight or obesity, which is an injectable medication. This is the randomized double-blinded phase 3 data from that trial. It focused mainly on, it was focused mainly in Asia. The data was published out of China. And so they defined overweight or obesity as a BMI greater than 28 kilogram per meter square or 24 kilogram per meter square with at least one weight-related comorbidity, but without diabetes. And then they looked at the change in percent in body weight, which we can see over here, which was around the highest dosage. They studied 1.2, 1.8, and 2.4 milligrams. At the highest dosage, we saw a 13.2% change in body weight at week 40. There was a less than 2% discontinuation due to the side effects, which was probably the least amount of all of the GLP trials. And then the triple hormone receptor agonist retatrutide. So I know a lot of us have heard about this and are eagerly awaiting it. It is a GLP-1 receptor agonist, a GIP agonist, as well as a glucagon agonist. So that's where the triple receptor is. And it was a phase 2 study was published in patients with obesity with a BMI greater than 30 or between 27 to 30 with at least one weight-related comorbidity. And the primary endpoint was change in body weight from baseline to 24 weeks. These were the multitude of dosage. They were studied at 1, 4 milligrams, 8 milligrams. And you could see here at the highest dosage, we are now looking at around 24.5% weight loss. So getting in the realm of what we would look at with bariatric surgery. In terms of the percent of patients achieving the weight loss, greater or equal to 15% at the highest dosage was 83% of patients. All of the prior trials had around 50 to 60% achieving greater than 15%. And we also have here the 60 to 70% of the population that achieved more than 20, and around 48% achieving more than 25%. In terms of the side effect profile, again, very much dose dependent, and the key ones seen were nausea, diarrhea, vomiting, and constipation. And they, as all drugs need to, they reported out on anti-drug antibodies, and the immunogenicity of this medication was very low. Okay, and then finally, once monthly, I call this is called Maritime. It's very hard to pronounce. It's a GLP-1 receptor agonist and GIP antagonist. So tirzepatide is a GIP agonist. This is a GIP antagonist. And why would something that does the opposite of tirzepatide potentially work? So first, I'm just going to go through the data, and then we'll talk a little bit more about what the mechanism is. But the change in body weight in the obesity cohort, these are the different dosages that were used: 140, 280, 420, given every 4 weeks or every 8 weeks. And you can see here that the change in weight was around 20%. And the change in body weight in the obesity with diabetes cohort was 17%. And the change in reduction in A1C seen in the obesity cohort without diabetes was around 0.5%. And that with the diabetes cohort was around 2.2. So data very similar to some of the prior GLPs we discussed. So why does this work? So GIP agonism, that's tirzepatide, it acts via GABAergic GIP receptor neurons in the CNS. It drives weight loss directly through central appetite suppression. And it is an action that is independent of the GLP-1 receptor. And as mentioned before, there is data to suggest that chronic GIP stimulation actually increases basal metabolic rate. Now, how does GIP antagonism work? So GIP antagonists actually work by enhancing the effects of the GLP mechanisms. And so it mimics GLP-1 receptor-mediated transcriptional activity in the hindbrain neurons. It acts by relieving the tonic inhibitory pathways through the hindbrain and enhancing GLP-1 action. And these were all mechanisms that were demonstrated in knockout mice. So again, both mechanisms, because of the way that they're working at the receptors, are causing a tremendous amount of weight loss. So moving on from glycemic changes and weight changes, we're looking at the cardiovascular outcomes. And so the effects on the cardiovascular system, you can see here that the black receptors are GLP. They're found on the atrial, ventricular, endocardial, endothelial cells, as well as the vascular smooth muscle cells. GIP are located mainly on the cardiac, the atrial, and ventricular cardiomyocytes, as well as the vascular smooth muscle cells. And then glucagon receptors have an additional site at the atrial cardiomyocyte. And overall, we can see that it is involved with plaque stabilization, reduction in blood pressure. Also, one of the things to note is that it does increase heart rate. So if you've noticed some patients have palpitations, that is through one of the effects of GLP-1 agonists. And then there is a reduction in the symptoms for heart failure. We don't have large outcome data, but we do have quality of life data that shows that there's improvement with heart failure. And so what was the data for cardiovascular outcomes with GLP-1 receptor agonists? So these first 3 trials, the leader looking at the liraglutide medication, Sustain 6 looking at semaglutide, and Rewind looking at dulaglutide, these were done in patients with diabetes. They showed a relative risk, which always is a nicer number to report out because it's a bigger number, showed a risk reduction by 13% for liraglutide, 12% for dulaglutide, and the Sustain, which was semaglutide, was 26%. The number needed to treat, you can see here, is a little high, but again, we're talking about major cardiovascular outcomes, and so because of that, it is considered to have a great benefit. The main driver in each of these 3 trials was in liraglutide was cardiovascular mortality, Sustain 6 was non-fatal strokes, and in the dulaglutide was non-fatal strokes. In the dulaglutide trial, it was primary prevention. These patients did not have high cardiovascular risk. Sustain 6 did have a very high cardiovascular risk. Also, why the trial, the follow-up period was only 2 years, because the patients were much higher risk, and so they were able to report out the number of events that they needed to. With the SELECT trial, which looked at semaglutide 2.4 in patients without diabetes, that also showed a relative risk reduction of 20%, with a number needed to treat of 67, and the key driver was non-fatal MIs. So moving on to the kidney. The trial that showed benefits of GLP-1 agonists in chronic kidney disease and diabetes was the FLOW trial. What they were looking at was the first major kidney disease event, or essentially progression of CKD. And they only used 1 milligram, as that was what was FDA approved at the time. And also you tend to use lower GLP dosages in patients with CKD because they're more vulnerable to fluid shifts. The mechanism of action that was hypothesized was that there are direct effects of GLP-1 receptor agonists on the kidney, which may include decrease in inflammation, oxidative stress, and fibrosis. And the intrinsic kidney and immune cells contain the GLP-1 receptor, and GLP-1 receptor agonists reduce cellular expression of pro-inflammatory and pro-fibrotic mediators. What you could see here is that in the Kaplan-Meier curves, the lines started separating very early on. Therefore, these effects were considered to be independent of weight loss because the weight loss was seen much later. SGLT2 inhibitors were only used in 16% of the patient population that was studied because the trial was started prior to establishing SGLT2 as a chronic kidney disease treatment. And then moving on to obstructive sleep apnea, this is pretty obvious because we know that weight is directly related to obstructive sleep apnea and causing apneic episodes. The trial 1 was focused on patients who were not on positive airway pressure and showed that there was a reduction in the number of apneic events per hour. And over here, trial 2 focused on patients who are already on CPAP. So regardless of whether your patient is on positive airway pressure or not, there were benefits shown in both categories. And finally, MASH outcomes. This is an interim analysis of the ESSENCE trial. The full data has not been published yet. So this is an ongoing phase 3 double-blinded RCT and looked at 1,197 patients with biopsy-defined MASH and fibrosis stage 2 or 3, and they were assigned to semaglutide weekly or placebo. And the primary endpoints were resolution of the steatohepatitis without worsening of liver fibrosis and a reduction in liver fibrosis without worsening of steatohepatitis. And the results interim analysis have so far shown that there was the steatohepatitis resolution with no worsening fibrosis was seen in 62.9% of the patients compared to 34.3%, which was found to be significant. And common adverse effects were very similar to the GI effects that we know about. Tirzepatide currently has ongoing phase 3 trials, and the phase 2b trials for tirzepatide have been promising so far. So now that we've established all the good, what about the bad? So gastrointestinal adverse effects. This is a class effect. We know that it works on the gut. It slows down gut motility. So there is dose-dependent, generally nausea, vomiting, diarrhea, constipation, typically happens during dose escalation. It has led to discontinuation of approximately 5 to 8% of patients of clinical trials for the injectable, obviously higher for the oral GLP agonists. Mitigation strategies generally involve slower titrations. Ask your patients to perhaps not titrate every 4 weeks, but to consider every 2 months or 3 months, or perhaps just keep them on the lowest dosage possible. Because as we've seen, some of the lower dosages that have been studied still have a lot of benefits. Give them dietary guidance. Smaller meals, larger meals are going to cause more of a gastrointestinal stretch. Slow down fatty meals will slow down gut motility. Consider the use of antiemetics PRN, and then obviously hold for during any acute GI illness. And so this was a study that was published in Gastroenterology, which was a meta-analysis of patients on GLPs compared to placebo-controlled. And so the only 2 signals that they saw were in gallstones and in heartburn. Everything else was not shown to be significant in this meta-analysis. So what about gallbladder and biliary disease? There's a higher risk versus placebo. It's accentuated at higher dosages and longer duration. It's multifactorial. There's rapid weight loss. There's gallbladder hypomotility, which predisposes the patients to have gallstones. So you want to make sure you counsel them about right upper quadrant pain and consider an ultrasound if they have symptoms. The absolute risk increase is around 27 events per 10,000 patient years. What about pancreatitis and pancreatic cancer? What's the signal? So for pancreatitis, it's very rare. There are mixed signals in randomized control trials and observational data, but we have to maintain a high clinical suspicion. One of the hypotheses is that there are GLP-1 receptors present in the exocrine pancreas, particularly in ductal and acinar cells, though the expression of this varies by species. And in humans, there are very inconsistent data showing the expression of GLP-1 receptors in the exocrine pancreas. But in animal studies, we see that there's an increased pancreatic enzyme production of amylase and lipase, increased cell turnover, and some ductal cell hyperplasia, which may theoretically predispose them to duct obstruction or acinar injury, leading to pancreatitis. Pancreatic cancer, a large cohort data didn't show any increased incidence over 7 to 9 years. So what about thyroid cancer? So the medication has labeling for medullary thyroid cancer. Why? Because the animal studies showed a clear risk in rodents of thyroid C-cell tumors with GLP-1 receptors. But again, humans are different than rats, which is good, which means that we have less C-cell density, and we may not respond similarly, but because of the animal studies, it carries the label. And in general, if a patient has a higher risk, they have MEN, they have a family history of medullary thyroid cancer, again, you want to avoid use. What about papillary thyroid cancer? So a while back in, I think, 2022, 23, there was some data that was published in Diabetes Care saying thyroid cancer is associated with GLP-1 receptor agonists. And then every patient called us up saying, we probably need to stop this medication. So those studies showed that there was an increase. These are, again, observational studies. They showed that there was an increased risk after year 1. And then there was a plateau. There were other large cohort studies that showed that there was no increased risk of papillary thyroid cancer. So what are we taking away? Because again, these are all observational studies. So the takeaway is that A, there's likely a surveillance bias, right? Patients on GLP-1s come in much more frequently, have more clinical monitoring, which can lead to detection of incidental thyroid nodules or cancers. Moreover, there is also an incubation period. The patient could have had papillary thyroid cancer in a tiny nodule to begin with, and it was just detected because within that first year, which is why we're seeing the increase only happen at year 1. There's no long-term data over 5 to 10 years and no data on those with existing thyroid cancer. Regardless, the absolute risk seems quite small, 1 per 1,000 person years or less. And so essentially avoid the use with genetic predisposition for medullary thyroid cancer. Diabetic retinopathy. So a lot of times patients question, am I going to go blind if I take this medication? And so what's the data on it? SUSTAIN-6, which looked at semaglutide that was published in 2016, was the only trial that had a signal of retinopathy increased risk. SUSTAIN 1 to 5 and 7, 10, the REWIND trial looking at dulaglutide, the LEADER trial, and the SELECT trial in patients who didn't have diabetes, none of them showed a risk or a signal for retinopathy. And so we can conclude that retinopathy is likely not directly linked to direct retinal toxicity, but due to the rapid reduction in A1C. As we know from prior trials, a rapid reduction in A1C predisposes someone to have an exacerbation of retinopathy, mainly because these patients have underlying microaneurysms and other things, and the sudden shift of osmotic pressure can change perfusion in these patients, leading to worsening retinopathy. And so the mitigation, make sure that they have their ophthalmology follow-ups when a rapid A1C drop is expected, and do a gradual intensification in these patients. And then there was a study that was published along non-arteritic ischemic optic neuropathy that was published in the JAMA in 2024, and the referral registry was the total N of the population was 16,800, looking at semaglutide against non-users, and what they found was a high incidence and high absolute risk. But again, this was a center that had a referral bias. Only patients who had these symptoms tended to go to this particular location. The only other trials that have shown this are mostly in the Netherlands and Denmark. And so they showed a 2.3 versus 0.9 absolute risk per 10,000 years. There were other trials looking at semaglutide and tirzepatide, and those did not show any kind of signal. So what's the takeaway? So observational studies are suggesting a possible 2 times relative risk of optic neuritis with semaglutide. The absolute risk is very low. It's 1 to 3 per 10,000 person years. The strongest signal in the referral center was in the referral center and the Danish registry cohorts, not replicated in other multinational data sets. The RCTs were never powered to be able to study this. what the European Medical Agency labeled it as a very rare side effect of GLPs. The FDA is currently reviewing it to see if it needs a label. So counsel your patients that are at higher risk, that are older age, have a disc at risk anatomy, diabetes, hypertension. Essentially, the hypothesis is that these patients have, again, underlying perfusion issues. When they go on GLP agents, because of fluid shifts that may happen, because of the symptoms of nausea or vomiting, it may cause a reduction in their intravascular volume, leading to a reduced perfusion. If this happens, then you want to essentially stop the medication and refer to ophthalmology. And what about pregnancy? Animal studies in rats and rabbits for GLP-1 receptors, including semaglutide and liraglutide, they showed reduced fetal weight, skeletal and visceral malformations at clinically relevant exposures, and an increased embryo-fetal loss. What about human studies? So the only study that was published was a Danish registry in 2023 with approximately 100 semaglutide, liraglutide exposed pregnancies that showed no statistically significant increase in major congenital malformations, but it did show a higher rate of miscarriage and preterm deliveries, which could have been confounded by maternal diabetes and obesity. So recommendations, because we're never going to have a randomized control trial on this, is to discontinue it and allow a washout period for both semaglutide and tirzepatide. What about the weight regain? So every patient always asks, can I take this for a short duration of time and then stop it once I reach my goal weight? And the data so far suggests, based on step 4 and SURMOUNT-4, is that the patients, 80% of these patients are regaining the weight. So essentially everything is reverting back to the way it was, and the patients are then regaining this weight. I don't think that there has been any analysis of the 20% of the population that does not regain weight, but there might be some specific characteristics or of them which allow them not to. And then another concern that we have is lean mass loss, right? So patients lose fat, that's great, right? Great for their metabolic health. If they lose muscle, we're scared, right? Muscle is great for your body. So what does the data show? Functional studies are suggesting that it's an adaptive remodeling, may not purely be harmful. And what was used in all of these studies, so this is the COURAGE phase 2 study that was looking at lean mass contribution from GLP-1 agonists. There were meta-analyses and also, again, reviews and other observational data. The range is very vast. It goes from 25 to 40%, which seems to be quite a lot. But the way that this was assessed was through DEXAs and MRIs. And what they used to use these in the clinical trials, they measure total lean tissue, which includes skeletal muscle, organs, connective tissue, water. So this doesn't reflect purely myofibrillar muscle loss, which is what we're looking at, right? So a muscle can have glycogen, it can have water. It is assessing the total amount of loss that's happening. In general, when there is weight loss, even if it's adaptive, you still want to make sure the patients are having some mitigation strategies in place, resistance training, adequate protein. There are combination therapies currently under investigation. The BELIEVE study, which is looking at semaglutide with bimagrumab, which is an activin antibody to help preserve muscle mass in addition to using semaglutide. And so we'll wait for the data from that to see if potentially we might be able to give patients an option of preserving muscle mass in addition to losing just fat. And then finally, if you recall of all the prior data that I showed, most of the studies show that patients that are achieving the 15% or the 20% weight loss was 50 to 60% of the patient population. What about the rest of them? Why are they not losing weight? And so that remains a great question. There are a lot of hypotheses. Do we have answers? No, but some of the hypotheses are that there could be different genetic backgrounds, different variants in the genes and the receptors of how they respond to GLP-1s, different microbiomes, different neurohormonal signaling going between the gut and the brain, and different amount of musculoskeletal activity, whether there's different insulin sensitivity or different metabolic activity. So definitely need more research into that. And I think the final question is really, which one's better, bariatric surgery or GLP-1 agonists? And is there data? The only data that we had was published in Nature Medicine, and it looked at macrovascular and microvascular outcomes of metabolic surgery versus GLP-1 receptor agonists in patients with diabetes and obesity. what it found was bariatric surgery was more beneficial. There was a higher reduction in events. But the patient's population that it looked at was predominantly on exenatide and liraglutide. There was only a small percent of less than 10% of the population that was on semaglutide and none on tirzepatide because they weren't at the time weren't in use. So we will need more data looking at semaglutide and tirzepatide and some of the upcoming medications to see how they fare head to head with bariatric surgery. And finally, the ugly misuse compounding coverage. So as everyone knows, coverage is the bane of our existence. We want to give patients medications and insurance does not. So right now, Medicare Part D may cover semaglutide Wegovy for cardiovascular risk reduction indication if the patient had a cardiovascular event in the past. It is not approved for obesity weight loss alone. There was a label expansion that happened in 2024, and it is also now available for chronic kidney disease, as well as Zepbound is available for obstructive sleep apnea. So those diagnoses codes may be able to get you the medication through insurance. And I think all of our fellows always ask this, why can't we just give GLP-1s to everyone if it makes them healthy? And at the end of the day, it comes to population health. These medications cost $1,500, $2,000 a month. Medicare and the government would be bankrupt if we provided these to patients. And so we need a better alternative, a better way. And compounded counterfeit products. So essentially, because these medications are expensive, we know that patients have kind of moved towards compounded medications that might be cheaper on the market. But again, the FDA warned against this. They're non-approved compounded medications and salt forms. So either the medication may not be active, it's not the active ingredient, or B, they are giving you too high of a dose and patients have been reporting to have severe side effects. So again, use only FDA-approved products from legitimate pharmacies. And I'm going to give one final plug into type 1. I feel like this is the ugly of GLP because GLP has progressed in every disease state and form. It has not progressed for type 1 patients with type T1D. The only study, there was a study published many years ago looking at liraglutide and patients with T1D as an adjunct therapy. There was a higher prevalence of hypoglycemic events, which is why people never pursued it further. But since then, T1D management has come a long way. There are now hybrid closed loops available, which reduce the events of hypoglycemia. And so this was a study published by Shah's group that looked at 72 adults with type 1 diabetes, had a BMI greater than 30 on AID. And then they looked at a primary endpoint of time in range greater than 70%, time below 70, which was less than 4%, and a greater or equal to 5% body weight loss. You can see here, this was semaglutide, and this was placebo. This is 36% of the patients met the primary outcome, 0% in placebo. So we have a long way to go with type 1 diabetes to get this approved because the patients deserve it. So putting it all together, this is the evidence for GLP-1. I don't know why it came up like that. I feel like it looked better on my PowerPoint. But essentially, semaglutide and tirzepatide are currently leading the way where we have data for obesity, type 2 diabetes. For semaglutide, we do have major adverse cardiovascular outcomes. Tirzepatide has a trial ongoing, data not published. There's benefits for semaglutide in nephropathy and MASH. Tirzepatide, we see benefits in MASH as well as prediabetes progression. And again, the other medications have fallen out of favor, mainly because we haven't shown the data similar to some of the newer medications. And this is kind of a summary of all the side effects that we listed. GI side effects are common. Cholecystitis, gallbladder disease, also pretty common. Pancreatitis is very uncommon. You could keep it on your potentials, but again, look for other causes. Did the patient have gallstones? Did the patient have hypertriglyceridemia? Another reason for the pancreatitis, because the possibility of it happening in a human is significantly less. Pancreatic cancer, there's no established concern. Thyroid C-cell tumors, the risk has occurred in rat models, has not really translated as much to humans because of the lower density of C-cells. Diabetic retinopathy, only observed with rapid A1C reduction, and then non-arteritic anterior ischemic optic neuropathy. It's very, very rare, should not be a reason why you avoid use. That's it. Thank you. I'm happy to take any questions.
This is Dr. Coben. Can you hear me?
Yes, we can hear you.
Wonderful. First of all, that was a magnificent talk, Nirali. A real tour de force about a really important topic where you combine the clinical, the basic science, the practical, and it was wonderful. And I hope that our fellowship candidates appreciate the strength of our teaching program. So thank you for a great talk. I have one question, and it's fairly current information. I wonder if you know more or could elaborate a little bit about the GIP effect, direct effect on fat metabolism. How much more is known of why and how that happens? I think many of us have suspected right along that there's a direct effect that's not brain or gut mediated, but directly on fat metabolism. And any of the other compounds, the non-GIPs and the newer agents, have they been investigated for direct effects on fat metabolism as a way of producing weight loss? So thank you for a great talk.
Thank you. So for the first comment for GIP, so there was data published, I think, in Cell Metabolism that looked at chronic stimulation of the GIP receptor. So as I was mentioning, GIP with acute stimulation actually leads to fat neutral to fat gain. When there is chronic stimulation at the GIP receptor, this data was showing that there is a mechanism by which there is futile calcium cycling, which is what I read about. And it essentially means that there is a lot of movement of calcium in and out of the cells when the GIP receptor is chronically stimulated, which then leads to an increased utilization of ATP and increasing the basal metabolic rate or thermogenesis that happens at rest. And so from all the data search that I did, that was the most recent hypotheses that I had seen that was kind of shown in animal studies.
Great. And any of the other agents, have they looked at fat metabolism at all with the newer non-GIP agents that cause weight loss, good weight loss?
No, so the only other ones are, so most of them were either biased GLP-1 agents, which again has shown data about how it works through the GIP receptor by not working on beta-arrestin. It's very similar to the non-peptides, which also is trying to preferentially activate the G receptor, not the beta-arrestin. And that's kind of the thought process with those newer medications. And then the only other one I believe is retatrutide, which was a glucagon stimulation, and in addition to GIP as well as GLP-1. And the glucagon part, I think the hypothesis is essentially that you're still having lipolysis, glycogenolysis happen because of glucagon, and the glucose is staying within check because of the concomitant activation of the GLP receptor. I don't know if there's been more looked into it specifically at the white adipose tissue level.
Great. Thank you so much.
Dr. Afel?
Are there any data with GLP-1 agonists and Alzheimer's disease, cognitive dysfunction?
Yes.
I think there's anecdotal reports about whether how well documented is it.
So because of the receptors, there is research ongoing. I don't have access to any of that trial information, but when you Google it, things come up that they are under investigation. I just don't think that they've been published.
So in terms of the retinal complications, even though they're rare, do you only refer patients for retinal exam if they have existing retinopathy, or which is a all covered story? I mean, there's so many people in GLP-1s that probably wouldn't be practical enough. We'll send them all to retinologists, but
I think that anyone with a high A1C regardless is at risk of having retinopathy because of the glycemic changes and the microaneurysms. So we would be sending them regardless to get their retinal exams. I don't think that patients who don't have diabetes are necessarily at risk. The data didn't show that either in the SELECT trial, that there was any increased uptake in patients who don't have diabetes. Dr. Junaid?
With regard to the lean body mass loss, whenever you lose weight, you lose that lean mass. Is there any evidence that the lean mass loss from GLP-1s is worse than if you have bariatric surgery?
No head-to-head data, but I think that there is a suspicion that there is a significant amount of lean muscle mass loss that's happening, which is why they are looking into the activin antibodies to preserve muscle mass. But I don't think that there's a head-to-head trial between the two. It's mostly observational data, meta-analyses, and other things.
Just another question following up on retinopathy. Would you recommend referral for anyone on GLP-1 who has a large family history of glaucoma?
To start, sorry,
High family history of glaucoma.
who has diabetes or does not have it?
They don't, but they have a high family history of glaucoma. Would you still recommend the GLP-1, pre-diabetic GLP-1?
I have still used it. I don't know of any existing data showing worsening of glaucoma at all. It was mostly retinal and the non-arteritic ischemic optic neuropathy, mostly just vascular changes that tend to happen in patients with diabetes. Okay, thank you, everyone. Oh, you got it. Okay, I was like, I don't know what's going on.
I read
Yes.
Are at 3, but I recept and I don't know which one you're talking about.